Thank you much, friends, for watching this video. I'm your clinical tutor. My name is Salah Abbas. I'm Associate Professor of Surgery at Deakin University in Victoria, Australia. I have been teaching medical students for several decades, and I am here to help you not only to pass your exam, but also to be confident when you are a doctor treating actual patients. And hence, I try to condense these lessons really to the core knowledge that I do expect you to know in your examination and also as a junior doctor. Now, today I chose to you an important topic, which is liver abscess. Liver abscess is not a common disease in general, but we see enough of it, and we see it every now and then. Now, by definition, liver abscess, like any other abscess, is a collection of necrotic inflammatory tissue caused by damage to that tissue either by bacteria or parasite or fungal infection. And fungal infection is very uncommon. The pattern of the type of the agent that lead to the infection varies according to the country. In developing countries, we have a lot of Amoebic histolytica, and which, as you know, infect the colon, and from there the blood stream will carry to the liver, leading to formation of an abscess in the liver, usually a single cavity liver abscess, but it could on occasion multiple cavities. While in developed countries, liver abscess is usually related to an infection elsewhere in the body, most often any organ that gets drained by the liver, which means the gastrointestinal tract, is the primary source for the sepsis. So, then you ask me who will actually is at risk of developing liver abscess if the disease is not that common. We know there are certain risk factors, and you need to, when you make the diagnosis, you need to consider the these factors in the pathogenesis and the cause of the liver abscess. In general, bacterial abscesses, which is the pyogenic abscess of the liver called as well, usually are related to infection elsewhere in the body. And that most commonly, that will be an abdominal type of sepsis. There's another category who's immunocompromised that are also at risk of developing pyogenic liver abscesses, and the common ones are diabetic patients and patients undergoing chemotherapy for any type of cancer. Now, biliary sepsis is an important source for liver abscess, and that starts with the gallbladder. Occasionally, the gallbladder become necrotic and lead to formation of an abscess in its cavity, and that could break into the liver tissue, leading to a liver abscess. So contiguous transmission from the gallbladder into the liver. And the other source, obviously, is ascending cholangitis in a patient who's got obstructed biliary tree, whether it's by stone stricture or cancer. Inflammatory bowel disease and colon cancer should always be in our mind when we are dealing with a patient who's proved to have pyogenic liver abscess, because that could be the source of the sepsis. As these patients with colon cancer and inflammatory bowel disease are These patients are usually have high risk for developing liver abscess, and that should be considered in the differential diagnosis. Also, we should consider any septic focus in the abdomen. If you get perforated diverticulitis or delayed treatment of appendicitis, that can lead to formation of liver abscess. Luckily enough, these type of scenarios are very rare. Now, a bit about the pathology of liver abscess. Liver abscess, when it happens, the source of the bacteria that enters into the liver parenchyma can be from three sources. It could be the venous supply, which comes from the portal vein, and the portal vein drains all the gastrointestinal tract, which is the most common site for a source for the sepsis. Organisms can come to the liver in patients who have bacteremia for other reasons via the hepatic arteries. Another possible route where the bacteria make its way to the liver parenchyma is via the biliary tree in patients who's got ascending cholangitis with obstructed biliary tree. These patients are usually jaundiced by the time you see them. Direct infiltration or direct invasion of bacteria into the liver is uncommon, but that can happen in patients who suffer liver injury and devitalized liver tissue, particularly when they get surgery. That can lead to direct transmission of the bacteria into the infarcted liver tissue or the hematoma caused by the injury, and that can lead to an abscess formation. Majority of the bacteria that cause liver abscess are the bacteria that is well known to us that lives in the gastrointestinal tract, and that's Escherichia coli and Klebsiella pneumonia, with also the possibility of bacteroids. Every now and then we see enterococci and gram-positive bacteria such as streptococci are also reported to cause liver abscess. Usually this type of abscess comes from the bloodstream from an infected focus elsewhere in the body. Amoebic liver abscess is caused by a parasite called Entamoeba histolytica, and typically when the radiologists drain the abscess looks like anchovy sauce or anchovy paste. This name has been coined to it for a long period of time, and everyone seemed to remember that for life. Another possibility of getting liver abscess or infection in the liver, which is pyogenic infection, is in patients who's got hydatid disease. The hydatid disease can die and then can get secondarily infected from other sources, which will lead to liver abscess. So that demonstrates to us that the source of the bacteria can be from anywhere, and also characterizes for us the type of the bacteria. Hence, we can plan for the treatment when we get a patient who is coming with a liver abscess. Now, how do these patients present? The presentation is basically non-specific. They will look like any patient who's got acute cholecystitis or ascending cholangitis. And that will include right upper quadrant pain, nausea, vomiting, patient feeling unwell, they have fever. When you examine them, they have a tender right upper quadrant, and their blood shows raised inflammatory marker in the form of CRP and neutrophils. You will find that the first investigation that we will do to this patient is an ultrasound. And typically on ultrasound, the lesion will look hypoechoic. And if there is debris or solid material within the cyst, then you might have an area that look echoic in the center of the abscess. You could see to your right-hand side a picture of an ultrasound that showed a big abscess cavity. Now, if the abscess has got gas bubbles, which is relatively common for abscesses, then that will be picked by the ultrasound scan. If we add a Doppler to the usual ultrasound, there's a Doppler probe, we can assess for the perfusion of the organ or the mass. And typically in this situation, because it's necrotic, dead tissue and purulent material, it would have no perfusion. There's no central perfusion inside the system. More recently, people are using contrast-enhanced ultrasound scan. And basically, it will show you the same characteristics, but it will, in the arterial phase, show you the enhancement of the periphery or the wall of the abscess, which is the area of active inflammation. And in the center, which is necrotic and septic and liquefied, there will be no enhancement with the ultrasound that's associated with contrast. Now, once we get an ultrasound scan for these patients, and yes, we think they have got a liver abscess, mandatory that we, after started them probably with some antibiotics and fluid, and we will cover the antibiotics later on, which should include metronidazole and third-generation cephalosporins or broad-spectrum penicillins such as tazocin. We treat them empirically to start with, and that can make a difference until we establish the diagnosis on the CT scan, which is the gold standard imaging modality for diagnosis of any liver lesion. And when we do a CT scan in our head, we are thinking about the differential diagnosis, because liver abscess could look like secondary liver lesions, could be similar to a necrotic peripheral cholangiocarcinoma. Infiltrative HCC can sometimes look like a liver abscess in terms of its enhancement. And also, if there is segmental liver infarction, for whatever reason, there will be dead tissue, and that will liquefy. And when you do an ultrasound scan, it could look like a liver abscess. So we have always to keep in our mind there are other possibilities, and we have to ensure that the patient does not have liver metastases other than a primary abscess. Also, when we look at the abscess, we have to always, when we get an abscess, we have to think about the possibility of the abscess being amoebic, and also the other possibility, which is pyogenic or a fungal infection, in order to be able to treat the patient so they don't miss or delay or get delay in the treatment if we don't start the patient immediately on the appropriate antibiotics. The best imaging modality, as I mentioned, is CT scan. And on the CT scan, the basic thing is that we will see a peripheral enhancement. So the lesion is peripherally enhancing, because this area is the interface between the abscess and the liver parenchyma and has good high blood flow. So it will be enhancing during the arterial phase, while the central part will be hypoattenuating and will show no signs of perfusion. Also, if there are gas bubbles, the CT scan will pick those. There is a particular sign which is called the double target sign. I have put it here on the CT scan. You see that there is central necrosis. There is a ring of enhancement, which is the wall of the abscess that has got high blood flow. And outside that wall is a layer of edema, and that layer of edema is part of the liver tissue. And the double target sign is pathognomonic for a pyogenic liver abscess. Now, we don't use MRI very often, but if there is suspicion of hepatocellular carcinoma or other primary cancers of the liver or metastases, then we might need MRI to clarify the picture more to us, and it will add a bit to the information that we have about the abscess. So on T1, the lesion will be hypo-intense, the entire lesion, and also it would be kind of heterogeneous in its appearance. However, patients who've got fungal abscess might have the appearance of hyper-intense. They might give us a hyper-intense picture on the T1 imaging. Now T2, because of the nature of the abscess and the fact that it contains a lot of water, the abscess will be hyper-intense on T2. Basically, it is related to how much liquid or water is in the abscess. That's why it will look hyper-intense. Also, you'll be able to see a perilesional edema, and that will manifest as a high signal hyperintensity on T2 weighted images. And on the enhanced MRI, we will get the T1 with contrast, and the contrast is gadolinium that we use for enhancement with MRI. This will show high enhancement and high perfusion of the capsule and absence of perfusion in the central part of the abscess cavity. Now, how are we going to treat them? Now, we took all the bloods from them. We made sure that the renal function is good and they are stable, but because sometimes they can be quite unwell and they might need to go to the intensive care unit. Now, the major modalities of treatment that we rely on to treat liver abscess is going to be antibiotics and percutaneous drainage with an interventional radiologist. We reserve surgery only for the most unusual cases. And patients who will need surgery, they are either septic or have got some multiple abscesses, and it's impossible to drain them radiologically, or if the abscess is situated deep in the liver, close to major blood vessel or viscera, where it is not accessible to the radiologist. But that should be the exceptional cases, as the majority will be managed non-operatively. With the antibiotics, as I mentioned, every patient should start on broad-spectrum antibiotics, either cephalosporin or broad-spectrum new penicillins, such as tazocin. Metronidazole should always be added, even in Western countries, because we still see amoebic abscess every now and then, and we don't want the treatment delayed until we get the diagnosis, which might not happen until a few days later on. We ask our interventional radiologists to have a look at the lesion and see if they can insert a drain in it. And if they can drain it, that will be the definitive treatment. We drain abscesses that are bigger than 3 centimeters. Abscesses that are less than 3 centimeters are usually treated solely with antibiotics, and they settle down on that. And once we clear the infection and the patient looks well, we leave the drain as long as it is producing, and we take that out when the drain stops producing purulent material. Then the patient gets discharged home, usually on antibiotics, in the form of oral tablets, and we give them back in 6 weeks, and we do a CT scan to see their progress and whether the lesion has settled or it might need some more treatment with antibiotics or further drainage. Now, there are complications that can happen after liver abscess, and these complications are you could get, in extreme situations, hepatic vein thrombosis. Unfortunately, that can be quite serious. And unfortunately, it is not a common condition because it can lead to liver damage and liver failure. Portal vein thrombosis, I've got a picture for you here. And this is the portal vein, and you see a filling defect inside the portal vein. This patient does not have an abscess, but just to show you how the thrombus inside the portal vein appears. If untreated, the abscess could rupture into other cavities and tissues. So it could lead to formation of a subphrenic abscess, or it bursts into the abdominal cavity and might lead to peritonitis. It can actually burst into the pericardium and lead to cardiac issues, and that might be quite a serious issue, not only because of the sepsis, but it will also impact on the mechanical activity of the heart. It could decompress itself into the gastrointestinal tract, such as the duodenum or the colon. And the other potential site for rupture, particularly in patients who's got amoebic liver abscess, is the pleura, and that can lead to empyema, which is generally more dangerous than the liver abscess itself, because the patient can get quite sick and they might need thoracotomy for and decortication in addition to the antibiotics for that treatment. Now, these patients, once we clear them well, in general, we get them in a few weeks' time, and we do a colonoscopy, unless it was an amoebic liver abscess. Now, amoebic liver abscess in the West is rare, but we still see it, and we see more pyogenic abscesses than amoebic abscesses. And with the pyogenic abscesses, where there is no obvious source from the gallbladder or the biliary tree, or some other intra-abdominal sepsis such as diverticulitis or appendicitis that has happened recently and could be considered as the cause of the liver abscess, then we always do a colonoscopy, and that's mainly to ensure they don't have inflammatory bowel disease or, more commonly, colon cancer. And colon cancer can ulcerate, and bacteria can travel via the capillaries into the portal vein and lead to liver abscess formation. Thank you for staying for the entire video with me today, and I will look forward to see you in future videos. As I said, we will continue to compile these videos, and I personally will try to cover all the topics in general surgery.